Warm greetings. Good afternoon to everyone. Welcome to our MASA webinar series organized by Faculty of Dentistry. Today, MASA constantly strives to continue imparting knowledge and updating with the latest development in the field of dentistry. As a part of our webinar series, today this webinar would cover in detail about the essentiality of early diagnosis of molar incisor hypomineralization in children. It is a great pleasure for me to introduce today's speaker, Dr. Laila Abd Jalil. Dr. Laila graduated from University Malaya, Kuala Lumpur, with a Bachelor of Dental Surgery and a Master of Science in Children Dentistry from Eastman Dental Institute, University of London. She also had the opportunity to continue her studies at Royal College of Surgeons, Edinburgh, and obtained a fellowship in dental surgery, Royal College of Surgeons, Edinburgh as well. She worked in the Ministry of Health as a specialist in the field of pediatric dentistry for 25 years in providing dental services to children in Malaysia and in Southeast Asian region, particularly in Negeri Sembilan. This includes advancing dental services for children and for the children with special needs throughout Malaysia, as well as training and advisory services on curriculum planning and the scope of pediatric dental services for master's and students' degrees at local universities and for the postgraduate. In addition, she was also active in improving dental services for children through the implementation of the studies and conferences, workshop, seminars, both domestically and internationally. She worked as a part-time lecturer in University Kembansan, Malaysia for 10 years and has helped to set up the pediatric dental department there. Without further ado, I would like to introduce Madam.
Okay. Thank you, Dr. Sai Pranoy, for your very kind and sweet introduction. The aim of today's talk is, the topic is on essentiality of early diagnosis of molar incisor hypomineralization in children. And the aim of this talk is to create awareness on the problems that will be encountered by dentists managing molar incisor hypomineralization and by patients suffering from it. MIH is a common developmental condition resulting in enamel defects in the first permanent molars and permanent incisors. These two teeth are very important teeth in a human dentition for aesthetics and also for function. The permanent incisors for aesthetic that were concerned with the self-esteem of the child, and of course for function, the first permanent molars. The prevalence of MIH appears to be increasing, and managing affected children is now a common problem for pediatric dentists. The content of this talk will be discussed under the following topics: introduction, prevalence, etiological factors, MIH characteristics, differential diagnosis, treatment approaches, and the conclusion. MIH or molar incisor hypomineralization is a quite frequently encountered dental condition with some significant complication that can affect the quality of life of the patient, as this condition can create some challenges in terms of treatment, which the affected tooth are prone to caries and can be presented as post-eruptive enamel breakdown. So due to these characteristics, it is responsible for the development of childhood caries, as the prevalence is quite high as well. By definition, molar incisor hypomineralization is a clinical diagnosis to describe hypomineralization of systemic origin that affects one to all of the first permanent molars and is often associated with affected permanent incisors. That is a definition by Wilhelm et al. In 2001. and it presents at, and MIH presents at eruption of these teeth. Other earlier nomenclature, the first report of MIH dates from the late 70s by Koch et al. And Koch called these defect as cheese molars. Other than that, they are also called non-fluoride enamel opacities, internal enamel hypoplasia, and idiopathic enamel opacities, to name some. The prevalence of MIH is about 2 to 40,000 across Europe, and the variation is due to examination variability, the different age group that were investigated, and the caries level that may be masking the true prevalence of MIH. MIH could be more prevalent in some countries than others, and there's no difference in prevalence between sexes. This is the prevalence of MIH in Malaysia is about 17,000. That is a study conducted by Hussein in 2015. Now we look at the etiology. The etiology of MIH is unknown, but the risk factors noted for MIH is in the past there were fever in the first year of birth, cyanosis, chickenpox, otitis media, ear infections, tonsillitis, urinary tract infections, GIT disorders, asthma, and allergies. And in the perinatal stages, such as infections during pregnancy, premature birth, birth complications, and family history of enamel defects. These conditions could probably cause alterations in the calcium phosphate balance or insufficient oxygen supply to amyloblasts, resulting in enamel defects. And other common conditions in the first years of life, such as asthma, chickenpox, measles, and rubella, are also associated with MIH. Other systemic illnesses associated with MIH, nutritional deficiencies, brain injury, cystic fibrosis, syndromes of dementia, and lead poisoning. Next, we look at the anatomopathology of MIH. There's hypomineralization in MIH begins at the amylo-enamel junction and not at the surface of the enamel. Okay, the affected enamel has about 20% less mineral concentration, and the protein content in MIH enamel is about 3 to 15-fold higher than some enamel. So in the mild MIH, there's hypomineralization. The hypomineralization remains limited to the inner enamel while the outer surface is intact. Whereas in the severe form of MIH, the whole enamel layer is hypomineralized. This is a section through an extracted MIH, the affected first molar. You can see showing the lesion extending from the amylo junction outwards through the occlusal surface. That means it starts from the amylo-dentinal junction with apparently unaffected cervical enamel. Hypomineralized enamel has been shown to have mechanical properties that are similar to those of dentin as opposed to those of sound enamel. So this 50 to 70% reduction in the mechanical properties suggests that a hypomineralized enamel has a low resistance to wear and will flex on loading, and that's the explanation why that gives the explanation why MIH affected teeth appear clinically weaker and more prone to fracture. And this is a slide that shows the scanning electron microscope examination of enamel surface without acid etching. Look at the final column. In the zone of moderate hypomineralization lesion, there was more porosity, larger cracks, and a larger quantity of scale-like lesions here. The microscopic changes under the scanning electron microscope, there's a varying degree of disorganization with increased porosities, and in the more severely affected areas, the rods are very thin with wide gaps in between, containing what appears to be organic material. So the border between the enamel, normal cervical enamel, and the affected occlusal part is always distinct. This is the scanning electron microscope examination with acid etching. Previously there was no etching. This is with the etching. Atypical features of etched enamel are one of the causes of poor addition of restorative materials to enamel on teeth and diagnosed with MIH. Okay, look at this column, last column here. Next, we come into the clinical characteristics of MIH. Okay, so how do we diagnose MIH? Any examination for MIH should be undertaken on clean, wet teeth at the age of 8 years old. This is the optimum age, as at this age, all permanent first molars and most of incisors have erupted. So in addition, the first permanent molar teeth will be relatively good, in a good condition without excessive post-eruptive breakdown. So remember the age, this is the best time to diagnose, to look out for molar incisor hypomineralisation. On the first permanent molars, common also on the incisors. So next, we look at the number. The two that it will be commonly affected will be the first permanent molars, and of course, and also often the permanent incisors. Okay, about the numbers. Numbers varies individually from 1 to 4 affected molars. So with or without representation on the numbers. So to diagnose MIH, it has to be presented on the molars. MIH has to be presented on the molars, but not on the incisors. That means if you have enamel opacities on the incisors and you diagnose that has MIH, that is not right. So it has to come from the molars first. So expression of defects may vary from molar to molar. Okay, so the numbers. Then we go into the severity, tooth number, and next the characteristics of MIH. The severity of MIH, the severity can be divided into mild and severe severity. So in the mild, there's intact contact, white or creamy in color opacities, hypomaturation where enamel appears almost normal, but sometimes have patchy appearance, and there's no breakdown in the mild form. Whereas in the severe form, there's hypocalcification where enamel appears discolored with yellow and brown opacities. There is also post-eruptive breakdown, which is difficult to detect on X-ray pre-eruptively. This breakdown happens due to weak enamel and large masticatory forces. And we have looked into severity. The next characteristics will be, that's just to show some of the pictures of teeth with MIH. This will be in the moderate form, and this will be the ones which is very severe, that's enamel, post-eruptive breakdown of enamel. Then we come into the structure of the tooth. Okay, MIH is a qualitative. It's a qualitative defect where the enamel matrix is normal but weak. It is soft, porous, and looks like discolored chalk or dyed cheese. Yellow or brownish in color, and sometimes in mild cases, white demarcation on cups and occlusal surfaces like snow cap appearance. Okay, and so you get it on top of the cups and it looks like snow cap. That's to say about the structure. And then this is the look at the structures. This is the mild type, and this is the moderate. This is the mild type, and this is the severe. Okay, the severe type. And next we come into the sensitivity. There will be extreme sensitivity presence towards air, cold, and warmth, as patient feels pain even after proper anesthesia administration. So due to this extreme sensitivity and pain, usually patient becomes reluctant to carry out effective oral hygiene regime and accept dental treatment. These patients with MIH are at risk of developing dental phobia and presenting behavior management problems. Next, we have caries formation due to the massive structure breakdown has the affected teeth are fragile. Patient will cause extreme sensitivity, and the patient will avoid brushing, and then caries will soon form due to its structure that is plaque retentive. Okay, the broken down enamel will cause plaque retention. See, that's caries setting here. Next photographs will show you the caries. Next characteristics of MIH, the seventh one is atypical restoration. See, you will notice extensive oddly shaped restoration seen on young permanent molars, whereas the other teeth are quite alright. But this one is extensive oddly shaped restoration seen on young first permanent molars, and that will ring you a bell to say that that could be because due to MIH. Okay, this involves multiple surfaces and usually does not retain well. Okay, the restoration does not retain well. Right, look at the slides and look at the first permanent molars, which is this is very extensive caries with atypical restoration, and this is as well. Whereas the other teeth, they are quite okay, they're quite sound, except for that one. Suddenly you just notice this big one which is out of place. Okay, that is the atypical restoration. Then the 8 characteristics of MIH is you will notice that first permanent molar, there's an early extraction of the first permanent molars. Maybe the child will be around 12 years old, 11 years old, and you look at the first permanent molars, they're not there due to extraction, early extraction. Okay, there is some of the characteristics of molar incisor hypomineralisation. Next, we go into differentiating it from other enamel hypoplasia, enamel opacities. Okay, other enamel opacities, the enamel developmental defect. Okay, so MIH can be confused with other developmental defect of enamel, example fluorosis, amelogenesis imperfecta, and enamel hypoplasia. So we can actually give you you can actually make comparisons between amelogenesis imperfecta and between MIH. Okay, so amelogenesis imperfecta, or AI, is a genetic disorder which results in enamel that is hypoplastic, hypomature, or hypomineralized, and it affects AI affects both dentitions, whereas MIH only affects permanent dentitions, but sometimes there's also is involved. Okay, there is, and most or all teeth are affected and may be detected pre-eruptively on radiograph for AI. Okay, but in MIH, it only affects the molars and incisors, and it cannot be detected in the radiograph. Other differential diagnosis, it could be fluorosis, but with fluorosis, the history is the take away clues. Okay, there's a specific this specific disturbance of tooth formation due to excessive fluoride ingestion, and is usually associated with history of fluoride ingestion during enamel development. So in fluorosis, the opacities will be diffuse, linear, patchy, confluent white opacities without a clear boundary, whereas in MIH, it is well demarcated borders of hypomineralized enamel seed. And fluorosis is caries resistant, whereas MIH is caries free, caries prone, sorry. So in fluorosis, it's symmetrically distributed and bilateral pattern, whereas in MIH is asymmetrical pattern. And in fluorosis, the mechanism actually is caused by, it could be due to drinking water with fluoride levels more than, fluoride levels 1 to 2 parts per million, or the overuse of fluoride supplements or toothpaste, which can cause mottling on the enamel severely. This is some examples of fluorosis. So it's bilateral distribution and almost all teeth are affected. And then we have, next is enamel hypoplasia. Deficiencies in enamel thickness resulting from stress during secretory phase of amelogenesis. So this is enamel hypoplasia. And the borders of the deficient enamel are smooth, whereas in MIH, it is well demarcated borders of hypomineralized enamel. And it is also caries resistant, whereas MIH is caries prone, and enamel hypoplasia is commonly symmetrical bilateral pattern, and there's chronological bending of abnormal enamel in horizontal distribution, whereas MIH is asymmetrical pattern. So you can see this is some of the enamel hypoplasia, which is systemically distributed with systemic manifestation. Okay, so you can see the chronological line to suggest to you at what age the etiological factors has come in. This is also systemic manifestation, whereas this is local manifestation of enamel hypoplasia. Next, we have tetracycline-induced enamel hypoplasia. It is a disturbance in an amelogenesis of permanent dentition, which high doses of tetracycline results in staining and sometimes severe enamel hypoplasia. So you can see. One time, tetracycline was the first line of therapy in treating infections caused by Mycoplasma pneumonia. So it's commonly given at that time. So those are some of the differential diagnoses of MIH. It is actually quite easily differentiated from other. MIH is quite easily differentiated from other enamel hypoplasias. And the clinical problems caused by MIH, one, to the dentist and also to the child, we will discuss that. One is there will be, for the dentist, there will be large immature pulp, there will be reduced crown height and exposed dentin. There's a long list here. And there's rapid dental caries progression, inability for the dentist to anesthetize the MIH molars, and also there's unpredictable behavior of apparently intact opacities. And restoration is quite difficult because of the bonding compromised. For the child, there's pain and sensitivity, and there will be pain when brushing, and also the appearance of the central incisors with enamel opacities. These are some of the effect on children's quality of life. Some questions and comments from the children which suffers from MIH. It hurts to brush my teeth, and the explanation is because teeth is too sensitive. And my teacher says I don't clean my teeth. That's because people think of disease are lack of brushing. Mother described child never smile. That's because children never like their appearance. And friends make fun of me. Social problem for the child, and my teeth have sharp edges. That's fractured enamel, and can't eat ice cream because of the significant sensitivity problem. And of course, dental anxiety due to many dental interventions. And also parents say child eats slowly because the teeth are so sensitive, and there's food trapping on food. There's food trapping, okay? So then let us look at the management. If we can divide the management into those factors: attend to symptoms, prevention, restorations, manage bulk health, and surgical. And I will actually I will concentrate more on managing the problems with managing bulk health. And we'll just discuss these other management problems in brief. Okay, and the objectives of management will be we will want to have a successful long-term restoration, and we want to preserve the crown anatomy. We want the pulp to mature with appropriate dentine deposition, and we would like to have a functional supported occlusion, healthy periodontal tissues, good aesthetics, and children also learn to develop coping mechanisms for future treatment. That will be our objectives of management. And the treatment of choice will of course depends on the status of the crown, the status of the pulp, the stage of root development, orthodontic considerations of the tooth and the arch, and as well, and psychological and behavioral factors as well. So the ultimate decision remains the long-term advisability of retaining the tooth and the ability to adequately restore the crown. So managing the crown, first we look at the restoration. We have the anterior teeth and also the posterior teeth. So the aims of restoration management for the anterior teeth, of course, will be improve aesthetic. And here we have some of the choice that you can have in managing the anterior teeth. You could have no treatment at all. If the patient is happy with the opacities, then it can be there. Or you can have this other option of remineralizing toothpaste on peptide, and this is also very good for sensitivity. Bleaching, plus minus etching, and plus minus sealing, microabrasion, plus minus infiltration, and composite, localized, or veneers. So this is the remineralization toothpaste, topical treatments to strengthen the teeth and reduce sensitivity. That's remineralization, and can be accomplished with casein, phosphopeptide, amorphous, calcium phosphate, CPP, ACP, oral care products. Okay. And these are some of the techniques for bleaching. You can actually refer to these slides, but my main concern will be on managing the pulp. You can also have microabrasion techniques. It's the technique that you can try, okay, and also this resin infiltration in combination with microabrasion. Okay, it can be alone or standalone, or it can be in combination with microabrasion technique. So this is the treatment done on with using icon infiltration, resin infiltration technique. And next we have management options for incisors with this is a colored chart from Queen's Mary Hospital, University of London. Professor Ferranti Wong has constructed this color chart, okay, and depending on the color of your enamel opacities, you can actually choose from here what will be the best management for such condition. Management of post-operative MIH, the aims is to reduce sensitivity, prevent wear and breakdown, maintain OVD, maintain arch length, and improve appearance. So this management can be carried out. You can have management, or you cannot have. There's no treatment required, or maybe there's no treatment required. Request by the patient. So then there's also remineralizing toothpaste or peptide, facial sealant, GIC restoration, composite restoration, preformed metal crowns, and laboratory fabricated restoration. So the goal of treatment, then we come into managing the pulp popper, because there's many patients coming to you with you will wonder whether the pulp is vital or the pulp is not vital before you proceed to do the other restorations. So manage the pulp. The main aim, the goal of treatment is to maintain a vital root forming organ as long as possible to allow physiological apical root formation. So if this happens, the rest of the treatment is routine endodontic treatment. So in the second important consideration in treating immature teeth is to keep the surgical procedure as superficial as possible with minimal instrumentation to not disturb the not yet fully formed roots. Okay, most of these children, they are in the group, the immature age group, immature permanent molars, that is the apex of the tooth are open, widely open. Okay, so this is characteristics of a study that is conducted on the pulpal status of hypomineralized permanent molars, and by Helen Road and friends, and this paper is on the characteristics of the pulp of the hypomineralized tooth, and the conclusion of that study, based on the immunocytochemical findings from this study, it appears that hypomineralized permanent first molars demonstrate changes in pulpal innervation, vascularity, and immune cell accumulation that are indicative of an inflammatory response. Okay, so that the pulp of MIH teeth are inflamed. Okay, so this will be the pulp treatment that can be carried out on immature tooth. I mean, young permanent teeth or open apex, vital pulpotomy therapy or non-vital pulpotomy therapy, non-vital pulp therapy or vital pulp therapy. You can have direct pulp capping, or you can have pulpotomy or exogenesis. And in the non-vital pulp therapy for young permanent teeth, we have a classification that is common, but now there's a paradigm shift of going to revascularization technique. The managing the pulp of immature MIH, it's very important to correctly diagnose the pulp. Okay, vital pulp should be asymptomatic. The tooth should be asymptomatic. It's hypersensitivity, and there's a reversible pulpitis, whereas in non-vital pulp, the pulpitis is irreversible and there's no necrotic pulp. Okay, pulpal assessment, direct pulpal evaluation, careful visual inspection, tactile evaluation during instrumentation, and even the detection of foul odors given off by a pulp provide important clues about lesion depth and pulpal status. There's a suggested outline for determining the pulpal status of curiously involved teeth in children. In children involves these following factors: visual and tactile examination of the crown and periodontium, pain from percussion, degree of mobility, palpation of surrounding soft tissues. And then there's the size, appearance, its amount of hemorrhage associated with pulp exposure, and also detection of foul odors of pulp that could tell you whether, give you some clues whether the pulp is vital or non-vital. And from the radiographic examination, you could see the extent of radiolucency of hypomineralized tissue, periradicular and furcation areas, pulpal canals, and periodontal space. And there will be also a history of spontaneous unprovoked pain and pain from mastication that will suggest to you that pulp is non-vital or irreversible pulpitis in the irreversible pulpitis stage. Pulp vitality test in young permanent teeth. The evaluation is an important aspect of treating immature teeth, but electric and thermal testing based on neural response of the pulp are most likely to give you false negative results, because the immature teeth and largely vascular supply, but do not yet fully develop neural innervation. Okay, that means they are very, the blood supply is very large, but the neural development is under development. So immature permanent teeth are not fully innervated with alpha myelinated axons, the neural components responsible for the pulpal pain response, and that reduces the numbers of pain receptors, making them less responsive to stimuli and giving you a false negative result. So hence, the need for using methods that test the circulation of the pulp is advised, like including example laser Doppler flowmeter. Okay. Treatment options of the pulp. Here's a long list: indirect pulp capping, severe pulpotomy, partial pulpotomy, epaxification, pulpectomy, revascularization, extraction, and autotransplantation. Let's see what we have here. Vital pulp therapy of teeth with molar incisor hypomineralisation, managed pulp exposure, and elective vital pulpotomy. This is an example that has been a paper that describes partial pulpotomy, young permanent teeth with teeth keratinization, and has advocated the use of partial pulpotomy in treating young permanent teeth with teeth keratinization. Okay, this is the procedure. You can see this is partial pulpotomy carried out using calcium hydroxide. And the conclusion from this study, the results indicated a high frequency of pulpal healing in young posterior teeth when superficial layers of the pulp beneath a carious exposure were removed, provided that all surrounding carious dentin was removed. So the pulp wound was dressed with calcium hydroxide and the coronal cavity was sealed with zinc oxide eugenol cement. However, more comprehensive studies are needed before this treatment. So it's a successful treatment, but it is recommended for routine clinic. It can be recommended for routine dental clinical use. And I've used these techniques quite a lot, and I find the success rate is very, very high. So what is vital pulpotomy? It is the surgical removal of a portion of the pulp presumed to be inflamed and quite possibly infected, leaving intact vital radicular pulp within canals, with the intent of maintaining the vitality of the remaining pulp tissues by means of a therapeutic dressing. So you will remove the infected pulp coronally and hoping the radicular pulp will survive and the root will continue with the closure. The common medicaments that we use for vital pulpotomy procedures will be calcium hydroxide and MTA. Okay, I use calcium hydroxide and MTA. Other medicaments can also be used. So indications for vital pulpotomy of permanent tooth: the tooth has no history of spontaneous pain, the tooth has acute minor pain that subsides with analgesic, tooth has no discomfort to percussion, no vestibular swelling, and no mobility. These are the indications for vital pulpotomy that you all can check. You can try and carry it out in the clinics. Indications for vital pulpotomy of hypomineralized tooth will be history of tooth has no history of spontaneous pain, tooth has acute minor pain that subsides with analgesics, regular hypersensitivity to hot, cold, sweet, or mechanical. And the complaint will be tooth has no discomfort to percussion, no vestibular swelling, and no mobility, and is restorable. Okay, the treatment would be absence of pathology at percussion, epicers, and treat when there's absence of pathology at percussion, epicers, and periodontia. Open epicers, preferably 3/4 form root. And during surgical procedure, tissue appears vital, absence of foul odor, and bleeding from the pulp excision site stops with isotonic saline irrigation within 2 minutes. So the bleeding stops easily when you amputate the pulp. The contraindications of doing vital pulpotomy, there's going to be a history of spontaneous pain. There will be profuse hemorrhage occurs on entering the pulp chamber, and the one-step pulpotomy is also contraindicated. Other contraindications are pathologic root resorption, roots that are toothed, resorbed, or internal root resorption, interradicular bone loss, presence of a fistula, presence of a pus in the chamber. Apexogenesis. So apexogenesis is a histological term that has been used to describe the result of vital pulp procedures that allow the continued physiologic development and formation of the root apex. Okay, so the goal of apexogenesis is the preservation of vital pulp tissue so that continued root development with apical closure may occur. Calcium hydroxide pulpotomy, this is very recommended in one of the studies and has advocated to use calcium hydroxide because of its properties. But I have also used MTA because of its properties as well. Okay, good properties as well when I compared it to calcium hydroxide because of the good healing. Good sealing properties of MTA. So calcium hydroxide has good clinical outcome. The pH 12 cause immediate necrosis of adjacent pulpal layer when applied. So necrosis is followed by inflammatory changes of underlying tissue, and after 4 weeks, a new odontoblastic layer and eventually a bridge of dentin develop. Okay, that's what we hope when we put in calcium hydroxide, a bridge will form to separate the coronal area with the radicular area. MTA is also very good. It is very biocompatible. The only thing is that it's very expensive. The compressive strength of the marginal adaptation and sealing ability is very good. It expands during setting and seals superiorly, and no microleakage any of the experimental specimens. So in terms of mineralization, MTA induced dentin bridge formation, and that gives better structural integrity than calcium hydroxide. So if you can afford to use MTA, it is a better option than calcium hydroxide. So coronal seal is very important when you carry out vital pulpotomy procedures, and usually the procedure is followed with the restoration of the tooth will be followed by stainless steel crowns. Okay, and I've used that technique and it is very successful. So this is the procedure that describes the calcium hydroxide vital pulpotomy procedures. You can check this later. That's the partial pulpotomy for caries calcium hydroxide, and this is partial pulpotomy procedures for carious exposures, that is severe pulpotomy. And this is wrong. This is not severe pulpotomy. Okay, I'm so sorry about this slide. This is for traumatic exposures. All right, that is called severe pulpotomy. This is the procedures done. Vital pulpotomy technique. You can look at the slides later. This is severe pulpotomy. And partial and coronal pulpotomy. This is comparing partial and coronal. In doing coronal pulpotomy, you remove the whole of the coronal pulp. Okay, then put in your MTA or your calcium hydroxide dressing. If with calcium hydroxide, you then put on another layer of dical on top to prevent the non-setting calcium hydroxide to sit on the pulp. So the rationale of those two medication, pulpal medication, studies have shown that in the pulpal subjacent area to a carious lesion just prior to soon after pulpal exposure, there will be bacterial components cause local irreversible changes. Abscesses or necrosis just beneath the exposure. The deeper remaining pulp continues to be free from significant inflammatory changes or infiltrate with inflammatory cells. So an infected pulp usually undergoes a degenerative process in a coronal to apical direction. So when pulpal infection and inflammation are restricted to the coronal portion of the pulp chamber, unaffected healthy pulp tissue remains in the deeper portion of the root canal system. So theoretically, removal of the compromised or infected tissue should lead to preservation of a remaining vital functioning pulp. In trauma cases, investigators report that the time between injury and treatment actually has limited influence on the outcome of partial pulpotomy. So partial pulpotomy rather than direct pulp capping or complete pulpotomy is the treatment of choice following traumatic or carious exposure in immature permanent teeth. Pulpal bleeding. Currently, the degree of pulpal bleeding is used as an indicator of pulpal inflammatory status. So increased bleeding on exposure site that is difficult to stop suggests that an inflammatory response extends deeper into the pulp tissue. So the treatment procedure should be modified, for example, by shifting the partial pulpotomy to coronal pulpotomy. Then in case when you remove the pulp, when you amputate the pulp, there's bleeding, continuous bleeding, you go further down into the coronal area until the whole coronal pulp is removed, until you get healthy bleeding from a healthy pulp. Okay, short bleeding, quick bleeding from a healthy pulp. Failure of bleeding to cease after 2 minutes of saline irrigation reveals an extensive pulpal inflammation in the working level. So it suggests that either more tissues need to be removed or an extensive procedure such as complete pulpotomy is indicated. The factors affecting the success of vital pulpotomy: the presence of an adequate blood supply, the presence of a healthy periodontia, good coronal seal, good coronal seal, and the prognosis, control of hemorrhage, and a suitable dressing material. Next, we have non-vital pulp treatment. We have gone through the vital pulp treatment that would be recommended to carry out in immature pulp with MIH tooth. Okay, the next will be a non-vital pulp treatment. there will be apexification procedure. So apexification, can you just look at this? Closure of root apex in a non-vital curious molar using long-term calcium hydroxide treatment. Okay, that's apexification procedure using calcium hydroxide into that is filled in the canal. It is a method, apexification is a method of inducing root enclosure of an incompletely formed non-vital permanent tooth by removing the coronal and non-vital radicular tissue just short of the root end and placing in the canal a suitable biocompatible agent such as calcium hydroxide, okay, and or MTA. So other than apexification procedures, there is also this new approach of treatment of non-vital pulp that we call revascularization. There's a paradigm shift, actually the restoration of a vascularity to a tissue or an organ, and this tissue generation, formation of a new tissue to produce both the anatomy and function of the original tissue. This is revascularization. So a paradigm shift of treating endodontically involved immature permanent teeth. You can try this technique and success is quite high. This is my patient that we have done a revascularization technique. Okay, you can see the continual root growth of the file. Okay, next will be, the last will be on a surgical approach, that is extraction and auto-transplantation. So extraction, the treatment decision, do the teeth have long-term viability? If no, when should you extract the teeth? When is the best time to extract? So the best time will be, if you look at the best time will be around the age of 9. If you look at this OPG, you can see that this is the MIH on the 6s, and that's the 7. The best time is to make sure that the 7 is forming at its bifurcation, that is, it's bifurcating, and you look at the 5 is at the crib of the E's, and also there must be the presence of the E's, okay, the 8s, I mean. So presence of 8s, 7 is at its bifurcation, and the 5 is at the crib of the E's. Okay, so you're going to extract this. This is the best time to extract the 6s. So can you see at 10 years old, the extraction has been done, and you can see these 7s and the 5 are in good contact. Okay. Next, we have auto-transplantation. That will be the last slides. The concept of auto-transplantation is the surgical transfer of a tooth from its original location in the mouth to another site in the same individual. So it is one of the clinical treatment options for missing teeth. And for the process involves extraction of a supernumerary tooth or a third molar and implanted into a recipient site. So you can see this successful immediate auto-transplantation done to replace the 6 by the 8 that is extracted and auto-transplanted into the 6th position. So this is just some examples that for patients that has come to my clinic very late stage, and we are unable to provide best optimum treatment for him. So that is to stress again, early diagnosis is very important. This is also another patient at 14 years old coming to the clinic for treatment. So finally, before I end this conclusion, research is needed to clarify etiological factors for prevention and early intervention. MIH can have far-reaching consequences for the child, therefore long-term consideration is needed. And refer to pediatric dental specialists for advice and management if necessary. With that, I thank you.
Thank you so much for a detailed and an elaborate session, madam. Your session was enlightening, and beyond doubt, this knowledge of MIH would help all the academicians, practitioners, and students to impart in their practice and studies. And unfortunately, we don't have live question and answers. Please feel free to comment your questions. We will get back to you with the answers. Thank you so much.